I just don't like how we've become really complacent, I think, about just saying, well, yeah, that's typical or normal. I come back and say, well, is it ideal?
Welcome to the Be Well Baby podcast. I'm Dr. Emily Spaeth, a physical therapist, lactation consultant, trauma-informed professional, and founder and CEO of Be Well Baby. We bring specialized services, including PT, OT, speech, and lactation, directly to families in their homes here in Portland, Oregon. I'm also the creator of the Beyond Birth Blueprint, where we virtually educate and coach families through pregnancy, postpartum, and especially babies. This podcast exists because healthcare for pregnant and postpartum people in this country is broken, and I think we can do better. So let's talk about it. Just a quick little loving note before we dive in. Everything that I share on this podcast is for educational and informational purposes only. It's not medical advice. It's not meant to replace care from your own healthcare provider. Every body, every pregnancy, every postpartum season is different, and you deserve support that's personalized to you. By listening, you agree to take full responsibility for your own health decisions. If something you hear sparks questions or concerns, or you want to reach out to my team, we would love to talk to you. Otherwise, reach out to your own healthcare provider because they probably would also love to talk to you. Okay, that's the grown-up stuff. Let's get into today's episode. Welcome back to the Be Well Baby podcast. Today, I'm talking with Dr. Stefani Hayes, a naturopathic physician and acupuncturist here in Portland, Oregon, who specializes in fertility, pregnancy, and postpartum care. In this episode, you are going to learn something that could genuinely change your life, or at least explain why you've been feeling so terrible. We're talking about iron deficiency and thyroid imbalances, two of the most overlooked and undertreated conditions in pregnancy and postpartum. Here's what we cover: the difference between iron deficiency and iron deficiency anemia and why that matters, what ferritin level you should actually be aiming for, and spoiler, it is way higher than most providers consider normal. I always tell my clients, maybe this is normal, but that doesn't mean that we don't have to do something about it. And we're talking about how low iron directly impacts your thyroid function and your milk supply. We'll also talk about the red flags of postpartum thyroiditis that often get dismissed as just having a baby, and exactly which labs to ask your provider for. Stay until the end because I'm going to share a story about a client of mine whose mysterious nerve pain, and we're talking full-blown carpal tunnel, tingling in her feet, nerve pain everywhere, turned out to be a connection to something surprisingly simple. Let's get into it.
Well, I'm really excited to talk to you about this because I think from my perspective, as a lactation consultant, I see so many people who are struggling with their milk supply and they have no idea that it has anything to do with their hormones. And I think it's way more common than people know. I have this sense that sometimes in our society, we just say, oh, well, you can't make enough milk, so
Good luck.
there's no answers. And I think that's where working with someone like you could be really, really beneficial. Why don't we dive in and tell us a little bit about first who you are and what you do and how you help your patients and your clients.
Oh, thanks. I'm Dr. Stefani Hayes. I'm a naturopathic physician. I'm an acupuncturist, and I work in Portland, Oregon. And my passion is working with individuals kind of preconception and then helping them get pregnant. Fertility is a special interest of mine and a specialty of mine. And then I work adjunctive during pregnancy. I'm not a midwife, but I like to help my mamas feel as optimal as possible and help their pregnancies go as well as possible. And then I kind of stay in the loop and support them in that postpartum time, because I think that's really, really important. And I don't think you and I agree that women aren't getting enough postpartum care, and that's really important.
Yeah, I think something that you said really jogged my memory, that the word optimal, I think there's this sense that in pregnancy, you're just uncomfortable and that's okay.
Yeah. I mean, I think that's the big thing that when we work adjunctive, we can help with, because I really value my midwifery and my OB/GYN colleagues they have a really hard job of keeping mom and baby safe and looking out for all of those really big risk factors. But yeah, there's a really big difference between everything being okay on that front and progressing normally or typically versus them feeling as good as they can. There's so often just dismissal, I think is the biggest way to describe it, of moms being tired in all these different stages and say, oh yeah, well, you're pregnant. Yeah, well, you have a baby. Oh yeah, well, you have a toddler. And there are so many ways that we can help them feel better. And it helps so many other parameters too, and other aspects of their quality of life and relationships and everything that's really important.
Yeah. So let's talk about being tired. What is like one of the biggest reasons that people are tired clinically that you see?
Mainly iron deficiency. And iron deficiency as a separate thing from iron deficiency anemia. So iron deficiency anemia is when it gets to the point that your body literally doesn't have enough iron to make the red blood cells the right size. But there's a really big transition there and something that's going on in the background when the body's using up its iron. And a lot of bodies, especially bodies with uteruses and ovaries, are really able to maintain their blood cell size and for a really long time, even when their iron stores are getting super, super low. But they can be incredibly symptomatic and have other concerns when their iron stores are low.
So that I feel like I've heard that the body sort of does everything that it can to be okay as it's growing another human.
Yeah.
And does that mean that the body is taking from the iron stores of the pregnant person?
I mean, there's so many ways in which iron needs to be utilized in pregnancy, and like early pregnancy, the blood volume doubles. I mean, that's just incredible. So making twice as many red blood cells. And so I think of the iron storage as like your pantry. And so some people go in with their pantry fully stocked and they're ready to, do that, really big lift that their body's doing at the beginning of pregnancy and then later throughout. And then others are going into it with their pantry half empty, 3/4 empty, and they don't know it. And so then when their body goes into that to double their blood volume, they're really symptomatic, really tired because they just didn't have that buffer. And yeah, the body is going to prioritize baby at all costs. It's going to, take it from mom's muscles and bones and brain and all kinds of places in order to get the fats the baby needs, get the iron that baby needs. And my advocacy is about, I want moms to feel good too while they're in this process. Because for me, it's not just about them getting pregnant. It's about that they enjoy that pregnancy as much as possible. And then that they're in the right space physiologically and psychologically, that they can enjoy baby postpartum too.
So let's talk about numbers. What are the numbers that you're looking for when you're looking at iron deficiency?
So I mainly look at ferritin. That's how I've been trained. And a lot of my hematology colleagues that specialize in it really just focus on ferritin too. There's a lot of other numbers that we can use in terms of iron binding capacity and things like that. But oftentimes those can really confuse the picture, and the actual pantry is ferritin. And so that's sort of telling me about iron store. Ideally, we'd see women holding their ferritin levels above 100. And that's nearly impossible with menstruating individuals because every month that there's a menstruation, there's a loss of blood. And through every pregnancy, with the actual growing of the baby and then the delivery of the baby, there's a loss of blood, and nursing comes from our blood stores too. So there's a whole utilization of that. Most individuals are symptomatic with iron deficiency when their ferritin gets below 30. Some of them get symptomatic when their ferritin gets below 50. So I'm trying in my best case scenario to hold them around at least at 70. That's my goal.
Wow. So the ideal is 100, but you're seeing people not get symptomatic until 30.
Well, I mean, and I meet people all the time where their ferritin's 7 or 20 or 13 or something there. And I mean, women are amazing at how they're able to just keep on keeping on. And, there's some of that just inherent sexism in our culture where they don't allow women to be symptomatic and they have to be these super moms. But there's also just an incredible resiliency of the bodies where a lot of individuals don't recognize that they're tired, or they've just been chronically iron deficient since they started menstruating. And so they don't really know anything different.
Wow. I'm sitting here thinking, well, I'm nursing and I'm 2 years postpartum, almost exactly. And am I iron deficient?
I think most menstruating individuals are. I mean, it's a lot of work to keep your iron stores up, and especially those who also have any GI conditions where they have trouble absorbing iron. Iron's a big molecule, or those who don't eat much of it directly, if they're vegetarian or vegan. And so there's a lot of additional aspects to it there.
But what do you do even if your iron is 70 and you're thinking, wow, this is great, but ideally it's 100. What are the things that we can do to help our iron stores?
I mean, if you eat healthy meat proteins, I think that can really help. And a lot of times cooking with cast iron, it's kind of old school, but that has some elemental iron in it. And so that really helps too. But I think just keeping an eye on it. It's part of my annual screening for all my patients. And when they're trying for pregnancy, I make sure I've got enough of a buffer. But as soon as they're pregnant, I mean, that blood volume changes in that first month. And so I'm watching their ferritin levels in those first 4 to 8 weeks and see how much of our buffer we lost. So right there is a piece. And then throughout the pregnancy, when I check at least every trimester and make sure I'm holding at least above 50. It's really hard to get anywhere near 70 to 100 during pregnancy unless you've had an iron infusion. So taking their prenatals, that has iron in it. And some people do well with supplementing with iron. Some can't absorb it very well, or they get really constipated. There's different forms of iron, some that don't upset the belly as much, like the iron bisglycinate and things like that are usually a little bit more tolerated. And some of the iron supplements have vitamin C and other things like that help people absorb them. But if you have access to getting iron infusions, I'm a huge fan of iron IVs. And we're lucky in Portland that a lot of our hospitals offer those. And most of the time, insurance is covering it for iron deficiency, not just iron deficiency anemia, especially if that ferritin has gotten under 30. And that's a pretty nice buffer. It's way higher than 7 or 5 to be at least.
In terms of the numbers, what is the difference between anemia and just iron deficiency?
Everybody kind of turns their red blood cells where they're actually getting low on their hemoglobin, their hematocrit, their red blood cell count. I've seen that happen for some people. They'll still have a normal complete blood count when they check their blood and their ferritin will still be low. Some people, those red blood cells and everything start changing. I've seen them when the ferritin's in the teens. But a lot of times with individuals, I'll see normal CBCs and their ferritin is down less than 10. So some of my patients it doesn't start showing up in the CBC until their ferritin might be 3 or 5, which again, that resiliency, the body's like holding on, making as good a red blood cells as it can forever and ever and ever till it peters out. So too often, I think we're just running CBCs to watch for anemias in pregnancy. And I think we're missing a lot of opportunity to give individuals more buffer with their energy, their mood, eventually with their lactation.
Yeah. Oh my gosh. Do you think that iron levels can impact lactation as well?
Yeah. Chinese medicine, we talk about the milk coming from the blood. We don't talk about that as much from Western medicine, but we definitely know that. I mean, there's so many connectivity aspects between iron deficiency and the other hormones that all affect lactation. But definitely, if an individual is iron deficient or anemic, they can make less blood. And you and I will talk more about thyroid, but the iron deficiency aspect then affects their thyroid, which affects their prolactin levels, which is really responsible for how their body is able to do that feedback loop with responding to baby. And so I think it's vital.
Yeah.
For women.
Oh, this is so fascinating. I feel like there's such a lack of understanding around this. I think especially in healthcare, like everyone knows that the milk that you make is coming from your blood. In a hospital setting, you have to wear gloves to handle other people's milk. It's excreted from the body, you know. And there's just this, like, I think there's this block between, like, oh yes, if your iron levels are low in your blood, that is impacting your milk. And yeah, that's huge for me, I think. And I think that back to the societal, you know, perspective of you're just tired because you had a baby. No, you might just be tired because your ferritin levels are 3.
It can be both, right? I just don't think that we should discount people's fatigue. And I'm also just not okay that they're super tired just because they had a baby. I mean, I don't want the postpartum experience to be entirely about fatigue. Of course, it's, you know, the babies are learning how to sleep and there's a whole big learning curve for the new parents. I just don't like how we've become really complacent, I think, about just saying, well, yeah, that's typical or normal. I come back and say, well, is it ideal?
Yeah. And so let's go back. We kind of touched on the thyroid and how ferritin levels and iron in your body can impact your thyroid. What, in terms of the thyroid, is the most common thing that you're seeing with your clients?
Well, mainly I'm working largely with my patients initially for their fertility. There is a really big focus with infertility or fertility support on making sure that the thyroid is optimal. It's actually one of the places that I feel like I'm speaking the same language as my reproductive endocrinology colleagues, which I'm really grateful for, because so often within natural medicine, with functional medicine, we have these tighter reference ranges in our lab, how we look at labs of not just what's pathological, but what is optimal. And looking at that. And in fertility medicine, we are kind of holding a nice optimal range with thyroid where we want the TSH between 1 and 2.5. And whereas a normal or not pathologic reference range might be like 0.4 to 4.0 or something on that thyroid reference range. And so often noticing some functional imbalances in the thyroid initially and choosing to treat them or not to help with the fertility. And then thyroid, just like the blood volume goes up, the requirement on the thyroid usually doubles in how much work it's having to do in pregnancy. So if it was already a little bit sleepy in the getting pregnant time, there's a lot more required of it. So even if it didn't need support before pregnancy, like to support it during. I mean, all of these hormones do a really complex dance with each other. I think of the endocrine organs as sisters. where the thyroid and the ovaries and the adrenal glands are all talking to each other. And when one is working harder at any point, it'll lean on the rest. And so you'll see them at different stages, they're working harder. And so when those ovarian hormones and pregnancy hormones really change postpartum, that puts another stressor on the thyroid, and the lack of sleep affecting the adrenal gland, all that stuff. So
you probably already have one of these, but if you don't, I wanted to tell you all about the Aura Ring. I started using it postpartum with my second baby so that I could actually see how poor my sleep quality was. And watching the subtle shifts over time has been incredible. It tracks your heart rate variability, your sleep, your recovery, even the little changes in your body temperature before you notice them. It was really amazing to see my stats change throughout my third pregnancy and then watch them improve postpartum. One of my favorite things, it actually gives me permission to rest. And as someone who struggles to rest, that is everything. It really points me to recovery in a way that nothing else does. You can click the link in the show notes for 10% off your Aura Ring, or if you already have one, grab one for your bestie or your mom for the holidays. They deserve rest too.
Can we kind of go back and talk for people who don't really know, like what the thyroid does and why it's important? Can we talk about what is the role of the thyroid and how does it get imbalanced? Especially, I think one of the biggest answers to the question of how does this all happen is the blood volume increases and the body has to catch up. But, there's postpartum thyroiditis, but there's also Graves' disease. There's so many different things that can happen with the thyroid that are either an hypothyroid or a hyperthyroid situation. So let's just kind of back up and talk about what is the thyroid doing for the body and why do we care?
oh my, the thyroid, so much for the body. At just baseline, it's helping us with our energy, our ability to get up out of bed and function. It affects our metabolism. So it helps with how we break down our food. I think of it literally as our furnace. It's like how we're taking in things and utilizing the fuel in our body and how well that's working. So if our furnace is turned way, way up, that's hyperthyroid, that's Graves' disease. Most people feel hot and have a lot of anxiety as their brain is just moving way too fast. Their bowels might be moving way too fast. And the opposite, if that furnace is turned way, way low, people feel really cold. Their bowels might move really slow and feel really tired. And tired can roll really easily into depression, just like that hyperthyroid can roll really easily into anxiety because the mood is so interlinked with all of those. So it also affects how we ovulate. It is affected by how we sleep. So there's so many ways in which thyroid comes into play. Well, you were asking about other reasons it can get off. Definitely family history is huge, especially maternal. If mom has a history of thyroid imbalances or grandma did, then there's more predisposition there. But there are more autoimmune conditions these days, and a lot of autoimmune conditions hold hands with other autoimmune conditions. And Graves' disease is a type of autoimmune condition of the thyroid. So is Hashimoto's hypothyroidism. And so oftentimes people who have other autoimmune conditions like celiac or rheumatoid arthritis or Sjogren's can develop some of these thyroid conditions too, whether just in general in their life or during some of these bigger times of stress on the body. There's so many joyous things about pregnancy, but it's hard on the body. And so there are some ways in which people are more vulnerable with different conditions that come during or post pregnancy.
So what is postpartum thyroiditis and how often are you seeing it?
Well, I never learned about it in med school. I think it's radically undervalued. So in the literature, they're saying it's about 5 to 7% of moms, which is decent. That's not like 0.5%, still quite a bit. But I think that a lot of people aren't looking for it. So I think that that number isn't really accurate. I think it's actually a lot higher. Is usually with the autoimmune response. So the immune system has to be kind of suppressed in pregnancy because we're carrying something that's not entirely ourselves in our body, and we don't want our immune system to get rid of it. And so when the immune system starts waking up a little bit more postpartum, oftentimes some autoimmune conditions that were stable that we knew about before can get really overactive. Sometimes autoimmune conditions can turn up for the first time. Almost always postpartum thyroiditis has some autoimmune response. Every once in a while I've seen it where it doesn't, but it's mainly, you know how with postpartum we notice and talk a lot about, let's say in that first month where women are having a lot of night sweats and their emotions are all over the place because their overall hormones are changing. So while that's happening, the thyroid is really changing in how much it was working. It was working twice as hard, and it's kind of finding its new balance in that postpartum time. If they're not sleeping, then it's trying to pick up the pace for the adrenal gland. And we'll see often people will go into a hyperthyroid state where the thyroid is overworking, running really fast, and then it really gets tired and it goes into a hypothyroid state. Sometimes it'll just stay in one of those or only be in one of those, but usually most of my patients, it swings from a hyper to a hypo. My very first patient that taught me about this, that I learned about it through her, was a mama. I think she was probably about 3 months postpartum, and she started having horrible insomnia and anxiety. And she went to her primary, and they thought it was just postpartum anxiety, which it could have been. But she just had this feeling about her body and her experience for herself with anxiety that was like, this doesn't feel like anxiety to me. This feels really different. And so she came to me, and I usually start postpartum with checking their iron and their thyroid, and her thyroid was a mess. And so
when you check the thyroid, what labs are you checking?
I mean, you'll be able to catch some of it with just TSH, and that's what a lot of MDs like to look at. For me as a provider, if I'm going to be helping them with treating it, I want to know more about what the thyroid's doing. The TSH is just what the brain thinks about the thyroid. I describe it as the nosy neighbor, where it's noticing if your lawn is overgrowing, if you're not coming out of the house. It's also noticing if you're having a party all night long. But the actual thyroid hormones that come from the thyroid itself and how the thyroid's working, not just what your neighbor thinks about it, are the free T3 and free T4. There's a bunch of other ones, but those are the ones that I lean into the most. They help me with my prescribing to make sure there's not an autoimmune component, or to make sure there is. I like to look, there's two thyroid antibodies that you look at. Thyroid peroxidase antibody, it's often abbreviated TPO, and antithyroglobulin antibody. And I definitely think it's good to check both, because I've seen where only one is elevated often, and you just don't know which one is going to be the one. So if you check only one, you might be missing the one that's off.
And that changes how you treat it.
For me, yeah, it changes how I treat it and how I understand it, if there's an autoimmune component or not. Usually with autoimmunity, when the body's making a mistake and kind of beating up on an endocrine organ or a gland like that, where it's just going to be more likely to bounce around quite a bit before it settles out. So postpartum thyroiditis has a lot of threads with that Hashimoto's hypothyroid, which affects people getting pregnant. It affects holding their pregnancy. It affects their pregnancy outcomes. So ideally, we're looking for this autoimmune response earlier on too. But every once in a while, the first time we see it is postpartum.
Mm. So, and Hashimoto's patients, Hashimoto's is kind of synonymous with hypothyroidism. Is that right?
It's a kind of autoimmune that causes the thyroid to work sluggishly.
Yeah. And those patients are at higher risk for postpartum thyroiditis.
Yes, very much so. I'm upwards of like half of those who have known thyroid antibodies before pregnancy or during pregnancy get postpartum thyroiditis. And I've seen stats even where like 80% of those who still have antibody activity in third trimester, like they're very highly likely to have a dysregulation in that, which is the postpartum thyroiditis, which makes sense, right? Autoimmune is where instead of fighting off viruses and bacteria, the immune system's making a mistake. It's fighting the actual thyroid gland. So the thyroid gland is vulnerable. It's literally getting a little bit beat up. And so in these times of big hormone transition where we need the thyroid to be able to flex through a lot of things, if it's going into that process really vulnerable, it's going to be more likely to kind of freak out. And that's what a postpartum thyroiditis feels like often to my patients, where it's way overactive and then it just crashes. It's way underactive.
Is it a one-time thing, like it's way overactive and then it crashes and then they're like, something is wrong? Or is it like a wave?
It really depends. Every body is different. Most of my patients will have a hyper swing where it'll be way overactive. I usually see that first, and that can last for a week or it could last for a month, but pretty quickly the thyroid burns itself out literally and then goes into that underactive, that hypothyroid state. And that it can hang out there for months. Ideally, somebody's watching it and can support it through that whole thing. And what's interesting about it, Emily, is that some people, this happens in their first month postpartum. Some it happens not until 3 months, 6 months, 9 months. Most of my patients, I see it before a year, but the literature says I sometimes see it as late as a year and a half postpartum. What I tell my patients postpartum is that I like checking in with them at least once a month, regardless, see how they're doing. But if at any point they are all of a sudden having insomnia, when not because of baby not sleeping, but like it's an opportunity to sleep and they'd been able to take those opportunities and now they can't, where they're just feeling incredibly anxious. You know, with postpartum anxiety, it can come in these waves where we worry and then it moves on, but where that anxiety is just holding steady and they can't make it calm down. Or the opposite, where they've been having okay energy. Sure, they have tired days, worse days, but overall their energy is okay. And then all of a sudden it's just bottomed out and just won't move. Same with their mood. We have little low mood dips that we get moments of sadness, moments of overwhelm that can push into sadness. But if it's just feeling like this super low mood that just hangs on for days and days, I think it's always good to rule out that it is a postpartum mood imbalance. But first, I think it's great to make sure that there's not an iron deficiency and or a thyroid imbalance. And so often my mental health nurse practitioner colleagues that I work with will have me kind of run the check on their iron and thyroid first and balance that first, and then see, is there any persistent anxiety, depression that we need to support with some neurotransmitter balance?
So we're talking about a bunch of different things. We've talked about hypothyroidism, where the thyroid is underactive, and that's the more like actual system slows down metabolically, like your digestion slows down and you're tired and fatigue is your existence. We have hyperthyroidism, where you're kind of going. That's the Graves' disease side of things. But then postpartum thyroiditis is almost, so itis is the ending of a word that means inflammation, right? So is it that the thyroid is inflamed actually, and therefore it's hyperthyroid followed by this crash?
Yeah, usually that's the understanding of it. When I feel people's thyroid, I don't always feel that swelling that might come with an inflammation, but that's kind of our best way to understand it. But it often has the reason for that inflammation, that getting beat up, is often that autoimmune component. But different than the Graves, where there are certain ways within autoimmunity with Graves that it runs this hyper state. With the postpartum thyroiditis is that, inflammatory process or overactivity that will push that roller coaster of both, where you'll usually get a hyper and then a hypo state.
The standard labs kind of often can miss it because they're only testing TSH. They're not actually testing the TPO antibodies.
Yes. And if they're looking at TSH just in that really big range, they might miss the early stages of something. They're not going to miss it when it really gets into a very hyper. It's going to be, on even those lab ranges, it'll be caught. And a very hypo, it'll be caught. But those in between, where it's starting or it's, in between its management process, the TSH. So let's say if I feel best at a TSH of 1 and my TSH has gone down to 0.8, that it happens, this opposite piece when the thyroid's more overactive. That's sort of a beginning stage for me, but it might not be diagnostic just with TSH until it's a 0.1. And every decimal point there matters. Same with a hypo state. If I feel good at a TSH of 1, I might be feeling really tired when my TSH has gotten to 2.5, 3, but it might not be diagnostic until, my postpartum thyroiditis patients, their TSH goes to 20 or 15, something crazy.
Actually, a higher number is hypothyroidism and a lower number is hyperthyroidism.
That's where you think about that nosy neighbor. It's like the neighbor is more nervous when you're underactive. So you're not mowing the lawn, you're not grabbing your mail out of the mailbox. And so the neighbor's knocking on the door a lot. So because it's that brain watching out for the thyroid. So when TSH goes up, it means the thyroid is working less. And when the TSH goes way down, that's when the neighbor's like, oh, I don't even want to talk to you. You're having a party all night long. You're way too loud. And so that's where it does that opposite.
Love that. I'm going to use that from now on. So the big red flags that I'm hearing are that anxiety that will not go away, insomnia that is different than just my baby's crying so I can't sleep.
No, those are big ones for that hyper state. That's what I see a lot. The other sensation my patients describe is like this buzzing sensation in their body, which feels a little different than most of us experience anxiety, where that gets more around our heart, in our chest, some shortness of breath, maybe our brain being really busy, but it's like the literal cells are firing too fast. And so they feel this they want to crawl out of their skin kind of feeling. And I've heard that described quite a bit in that hyper state. So I'd watch for that too.
Those are really good. The 3 red flags for hyper are a buzzing sensation, which it's so funny you say that. I'm thinking back to my 3 postpartum experiences and I'm like, I think I have felt that before. So the buzzing sensation in your body, anxiety that will not shift, and the insomnia, so inability to sleep despite having the opportunity to sleep. On the hypo side, so if you've passed the buzzing, you, like me, you ignored the buzzing cells in your body, and then you kind of crash on the other end. That's the fatigue that you just cannot get out of bed kind of fatigue and depression. But it's probably easy for especially somebody's partner to worry about postpartum depression. Everyone talks about baby blues, and that if you're not coming back out of it, we need to really address it. But that maybe the first line should be to test your iron levels, to test your thyroid.
I think so, because all of those things can make somebody more tired, which makes them more sad or more vulnerable to feeling stuck in that sadness. And I'm a deep, deep believer in, watching for the actual sort of postpartum anxiety and depression. It's really, really important. And I think part of the way we do that is a preventative way. It's some of these things that can predispose somebody for that. But yeah, the hypo state is very tired. Like they just got, it's like right after the flu where you just feel like you just can't get up. And so all of that compensating that women often do, that super mom where they're just going, this one's harder to push through. I don't want anybody to have to push through any of them, but this fatigue usually feels like one you can't ignore. And it can have that really low mood with it. Some people get constipated with it, but the biggest is just exhausted.
Yeah. So there's some really clear things that people can do this week if they're feeling these sensations or they've noticed this in their body. Or if they're currently postpartum, this is like the best time to listen to a podcast, right? Because you're postpartum, you're not doing anything except for trying to figure out feeding your baby. So if you're sitting there thinking, oh my gosh, I have felt the buzzing that Emily was saying that she felt, then they should be asking their provider for TSH, free T3, free T4, the TPO antibodies, and the thyroglobulin antibodies.
Yeah,
and iron and ferritin levels.
Yeah. And yeah, I mean, of course, get a CBC because that will keep everybody happy. But yeah, ferritin level is huge. And if their provider is not compliant, if their provider doesn't want to help, we're lucky now we have some labs that patients can order themselves. One of my patients recently told me about Jason Health, where it's through Quest, which is a really great diagnostic company, and patients can just order some of the labs really affordably for themselves. I don't advise that, but sometimes there is that spot that individuals get stuck in, especially our pregnant and postpartum mamas, where they're just not taken seriously, unfortunately. And so if their provider just wants to just keep telling them it's just because they got a baby at home, they could run the labs themselves and then bring it in and show the labs to their provider.
What about the person who's listening to this 5 years postpartum or more than that and thinking, oh man, maybe I did have this whole postpartum thyroiditis and I just didn't know. Or maybe throughout my pregnancy, I was iron deficient and I just didn't know. What are sort of like the long-term things that you see with somebody who doesn't address this in postpartum, prenatally or postpartum?
I mean, from the thyroid lens, most people struggle through it and they come out the other side, and usually their thyroid will find its way back to a normal functioning. But it's a really hard couple months for their body and their spouse. And I just don't like, it's hard enough. I don't need to add in harder things. Most of the time, I meet women like yourself who wonder if they had it with a former pregnancy. And if we're going into the next pregnancy or getting ready for the next pregnancy, we can use that information to be much more proactive and have a really different postpartum and pregnancy experience with having their thyroid better managed. Because if we have them on some thyroid medication in like getting pregnant, especially in pregnancy, and we're keeping their thyroid really happy, then it's not as susceptible to the getting beat up and doing this roller coaster. It might still do a roller coaster, but it's much more of a kiddie roller coaster than like a really scary one. The iron deficiency, I meet women all the time who have not been optimized, or they slowly with diet, you can get yourself out of an iron deficiency place. The trickier part with iron deficiency is that when our iron gets low enough, it makes it really hard for us to clot very well. And so sometimes our periods can become heavier. And so then it gets on this really bad cycle of you're already low on your iron, but you're bleeding more. And significantly, we'll see that in a perimenopausal time, if we've got many years of kind of accumulation of iron deficiency. But I know a lot of individuals who are a couple years out from postpartum and having flooding periods. And So it's definitely worth that. For me, is a red flag for iron deficiency. Usually those really big ones, that's when their body's to the point that they can't clot very well, their uterus can't contract very well to hold in the blood. And so, I mean, I love to have a preventative lens. If we can use, it's crappy to have to go through it once with a pregnancy. But if you're wanting to have another and we can do it different, we can help with your energy in the pregnancy. We can help minimize your risk of a lot of bleeding with the delivery. We could help with your nursing postpartum. We could help with your mood postpartum and be preventative on all those things. If we're more proactive with your iron, I think that can make a really big difference. But I want to be clear that none of this is anybody's fault. It's a systemic thing where we're not valuing our women as much in our culture, and even our female providers, because our system does have a lot of institutionalized sexism in it. We just aren't researching enough about women. We're not talking enough about preventative strategies. And so this is where this kind of underground network we share with each other, and you advocate, you ask for a ferritin, and you find a provider that'll take it seriously enough to get you an IV of iron. As if your iron is lower than 30 and you're menstruating and or lactating or both, it is so hard to boost your iron enough just with supplements and food. And while you're losing iron every month with a bleed and or also with nursing, it's so hard to get ahead of that. So that's why I like an IV. It just shoots us.
Totally. And I think I love that you're saying that it's nobody's fault. I hope that this conversation is validating for people who've been through this and not realized that they were going through this, and can look back and say, oh, there was actually a hormonal thing going on that, we all just didn't know enough to address.
If your baby ever needs a pacifier, and not all babies do, the one that I would want in your world is the Ninny. It's the only pacifier designed to actually mimic the shape and function of the breast. It looks like this. It's very soft here, like an areola, and then harder, like a nipple. And this shape means that it supports healthy oral development instead of interfering with it. I really love it because babies don't just passively hold it in their mouth like the ones with the bulb on the end. They have to actively suck. It's hard work. It's my workout pacifier. And that matters for feeding, for regulation, and for long-term oral function. It's especially beautiful for breastfed babies who need a little extra soothing without confusion. If you're listening and you're pregnant, postpartum, or buying for someone you love, you can grab a Ninny through the link in the show notes or use the code BeWellBaby for 10% off at checkout. It's one of these tiny little tools that makes a huge difference. And my favorite part about it is that babies don't get dependent on it. All right, let's get back to the show.
One of the things that I love about going to different providers and asking for different blood tests is that you might be part of educating them. Most providers didn't get into medicine to give you a hard time. Like, they wanted to help. And so there's this opportunity that we have to be like, okay, there's so much research now about the thyroid, but it's still not enough. And for us and me in this moment, I would like to know the numbers. And it can be really informative to your provider if that's not something they were planning on testing.
Yeah, and really empowering. And it's always this fine line with how do we not just tell our providers what to do? We're a collaborative force in it, and having compassion for the providers. You're right. They really want to help. And I've learned literally everything I know about postpartum thyroiditis from my patients, and then from watching for it to help prevent it for other patients. And endocrinologists know quite a bit about it. So within the medical field, they're the specialty that know about it. So if you're living in a place where your primary or your OB is not as helpful with it, then get a referral to an endocrinologist. If you have Hashimoto's and wonder if you're getting postpartum thyroiditis or it runs in your family, that would be your person. And same with iron deficiency, hematologists know about it, care about it a lot, especially women hematologists that are working, and sort of a lot of them are really becoming big advocates for how to optimize iron versus just iron deficiency anemia. But unfortunately, our midwives, our OBs are still learning about it. So having compassion and helping bring them into the fold. But if they're not being helpful, then ask for that referral to hematology. And that's where you can, or if you could find a great naturopath or functional medicine doc, lean into them too, because they care about it.
Ideal. Well, I have just really, really loved talking about this. I feel like I could ask you questions all day. But is there anything that I didn't ask you that you feel like is so important for people to know about this particular topic?
I think it's about women really trusting their body and trusting their knowledge of their own body. You've lived in your body a long time, and you know what is an extreme level of fatigue for you. And you know what is a lot more anxiety or depression than you encounter sometimes. And to not let somebody talk you out of that or tell you that that's normal. If you really don't feel right in your body, then be persistent and have your helpers, your friends, your spouse, your family members go with you to visits if you're too tired to be able to advocate for yourself. And as my saddest experience is hearing that patients have been trying to get treatment and they just have been gaslit and turned away and just told that it's normal, it's normal, it's normal.
I think one of the most impactful stories that I heard recently, I hear impactful stories all the time, but one of my clients went in and she was, 36 weeks pregnant, and she just felt like something wasn't quite right. And her baby hadn't really been moving as much. And for me, my placentas have always been anterior, so I haven't felt my babies move. And I'm like, don't stress yourself out about the kicks and things like that. But for her, she had been feeling her baby move a lot, and then she wasn't all of a sudden. And so she went in, and baby was okay on the non-stress test. There was nothing jarring for anyone. Everyone sort of was like, yeah, seems like things were probably okay. But she just had this feeling that things were not okay. And so she went in and was like, we're going to get a C-section. And they were like, okay, up to you. And she is so, so grateful that she had that wherewithal to listen to herself because she had a placental abruption. I know. It's like so remarkable that in this day and age, we are just taught so much to ignore our bodies, and that she was able in that moment to say, no, I really think there's something wrong. And she was right. And that everything aligned for everyone to kind of kick into action, and everyone was okay. So that brings me so much hope. But the most important piece of that was actually that this person is a medical provider. So it can't just be those of us who have been trained in healthcare that are taught to trust our intuitions,
Yeah. And I mean, I think for all of us, sometimes when we're trained in healthcare, we forget some about our intuition, but like how to hold on to that. And there is such a fine line in our culture between what is fear that we have inherited from stories that we've read or that our friends or family members have experienced, and what is our intuition. I definitely see my patients often in pregnancy like that, where they talk themselves out of even going to get checked because they're like, oh, I'm just being a hypochondriac with it. And I do think that when we allow ourselves to trust that voice, we do know the difference between just being worried and fearful about all the things in the check boxes and like really feeling like something's not right. And I absolutely agree with Emily. Like, just keep advocating for yourself when you have that, and don't talk yourself out of it or let somebody talk you out of it.
And even if you're in that like hypothyroid state right now and you're like, I can't even get up off the couch, how am I going to go get my blood tested? Tell your partner that like this is important and that you have to, but you really don't want to get up. Call your doctor. They have to do it for you, you know?
I mean, there are mobile phlebotomists. There are phlebotomists that can come to your house and draw your blood. There are ways to navigate it, but I don't know. Part of what I love about these is that iron impacts so many things, and it's relatively easy for us to treat it, which is so amazing that, that could be the key to helping with the milk production, or helping with the mood, or, helping with your heavy bleeds, those kind of things. And of course, the chronic fatigue. I like it when it's ultimately not, crazy complex. Iron's hard for us to hold on to, but if we're proactive about it, we can do a really good job. And the same with the thyroid. I think just if you needed thyroid to get pregnant, you need thyroid to stay pregnant. You'll need thyroid to support you postpartum. So just find somebody that can hold that thread for you, because different providers are going to be in those spots in between. And if your birth provider is not helping you postpartum, then they're going to just take you off it. That's not always the answer. It's more about who do you hand it over to. As you and I were talking, Emily, about how postpartum isn't just like the first month or the first year. Like, my mental health prescribers talk about the first 5 years. And that really makes a ton of sense to me when I think about, a newborn baby that can't hold up its head, and all the changes that have to happen until it goes to kindergarten, and all of the ways that affects the whole family, the birth mom, and then also the partners and the other kids in the house. And so how can we help more families be more vibrant and balanced?
It's really easy to just try and put one foot in front of the other to get to the next day and not realize that you could feel better.
Yeah, absolutely. Absolutely. We're all doing the best we can. We really are. And everybody does have some level of fatigue. But if you feel crappy, then there's probably something else. And yeah, so taking the time and getting the help to find the person who's gonna, give you a leg up in this, so that it can be a little bit easier, and finding that grace. And that's often there. Our bodies do so much work to grow a baby and birth a baby. And so, of course, they're going to be deficient in some way, right? And what we didn't talk about as much was how the iron affects the thyroid, but it's like iron is an ingredient for the thyroid. It's like, so if your pantry's empty, you can't make that ingredient. So you're going to be more susceptible to these things. So I don't know. I think if my take home's anything, it's like, check your Ferritin.
Thing that you can do, no matter where you are in your prenatal postpartum journey, is get your ferritin checked.
And then check it again. Just because it's like at 50 right now doesn't mean it'll be there in 2 months if you're more tired and your baby's grown a ton. Check it again.
Check it again. It has been such a pleasure talking to you.
Thanks for having me. It's been really fun.
Share a little bit about where people can find you if they want to get in touch with you, or especially if people are listening to this locally in Portland, Oregon, if they want to come see you.
I'd love to see people. I work at a big integrative care clinic called Kuan Yin Healing Arts Center. It's in Northwest Portland on 23rd and Flanders. And I'm blessed that I have a lovely team that supports me. And we try and take a lot of insurance to support as many patients as possible. If you can't get in to see me, you can get in to see one of my team members. But we love being adjunctive at whatever part of the journey you're at. If you're thinking about pregnancy, you're already pregnant, you're having trouble getting pregnant, or you're postpartum after all the babies, or after one and want to do it different for baby two, we'd be honored to walk beside you and see how we can help it be a little bit easier.
Awesome. Thank you so much, Stephanie. Do you have like a long wait list for people to come in and see you specifically?
You know, usually initially when they call, it would look like it's about 2 months out, which isn't crazy. But I get a lot of cancellations most weeks. The wait list is quite active. So I get my wait list patients in really fast because life happens, right? Especially with this clientele. And so I usually have 1 or 2 openings a week that we call my wait list on. So usually if somebody initially can't maybe get in with me right now till December or January, it ends up being that they'll see me a lot sooner than that. But my postgraduate fellows who you met are amazing. They're really lovely and really talented, and we all work really closely. So even if they don't see me directly, I'm kind of always behind the scenes.
I know I've been in this situation where, you know, the postgraduate fellow is the person seeing me, but then they're like, let me go ask a question really quick.
I think that's the best thing. I want my seasoned providers asking questions too, you know? So I like that humility.
I know, me too. I think actually my first profession of the like 25 things that I've done was as a yoga teacher.
Oh, okay.
And my yoga teacher always said that the best students are intermediate students.
Mm-hmm.
And I love that because and I think about it all the time. I say it to my physical therapy students because I'm a professor at Pacific. And it's so true that like an intermediate student always knows that they have more to learn, but they also have a lot of knowledge. And so I sort of strive to be that in life.
Always stay intermediate. Yeah. I mean, me too. I think it's why I love collaborative care because it keeps me really humble and I can lean into my colleagues. And you like when you're working closely with people, you always see how you might have a little bit more knowledge than someone here, but you have less. Like it keeps you humble. And I just love the opportunity for somebody to say, oh, I found this article or I figured this one thing out that we've been, wondering about, that kind of thing. And so, yeah.
The lactation consultant on my team has 18 years of experience as a lactation consultant. And for me, that is so valuable because I know what I know from working in the NICU. I know what I know from doing home visits, but I don't have 18 years of experience. So there's nothing that can kind of replace that. And her ability to want to do the most recent continuing education right now, her thing is like these flange fittings that we've been flange fitting everyone wrong forever. So now we do flange fitting pop-ups that are like getting you the exact size and shape that's like perfect for your body. And she does it at every home visit as well.
Sometimes it's those little tricks. And I do think it's different where when you have that much experience and what you've learned from that experience is from all the different patients and how it's influenced you. That's sort of different than sometimes, I don't know, our surgeons get or things like that, where they might not have as much of those nuance.
It's hard because with surgery, you're not like interacting that much.
I mean, they learn a lot, they see a lot of different bodies, but I think there's something different about like being in the trenches with people. And I don't know, I feel like the bulk of what I've learned over the years, I've learned from my patients or from what their conditions have prompted me to learn, And I love working with providers too. So, if there are some providers that are interested in learning more about how to adjunctively manage, because so many of us were taught to just not touch pregnant women and be really intimidated by postpartum. And there's so many gentle things that you and I both know that will make a really big difference to just being present during that. So I'm happy to support that way too.
So you offer mentorship?
I do. Yeah. I have a training organization that I do with a colleague. It's called The Art of Fertility. And we have virtual classes and we do mentorship. A lot of it's about the getting pregnant, but there's quite a bit about the staying pregnant and helping be as healthy as possible postpartum too.
That's for providers.
Yeah, that's for providers.
Oh,
Well, this has been so much fun. Thank you, Emily.
amazing. I learned a lot too. And I'm just really grateful for all of the stuff that you do. And I'm so excited to be able to, when you know something, but then when you talk about it, you start to see it everywhere.
Oh my goodness. Yes, absolutely.
I just feel like every single person I see, I'm going to tell.
Yeah, I bet they actually are. You should see, I don't know who all can prescribe the infusions, but you should check and see, because it's outpatient. We can prescribe them at OHSU, and Providence is harder outpatient, but Legacy is pretty great for us being able. So I don't know what all levels of provider they allow infusion orders from. But even if you just ran a Ferritin and then sent somebody to like Boost IV, even if we weren't trying to go through their insurance or something, Boost IV does Venifer infusions. They do 100 or 200 milligram Venifer, and all the person has to have is a recent Ferritin. So the person could, if they can't get it through an insurance or can't find a provider that's going to order. But OHSU does the Venifer ones. Usually you're looking for trying to get somebody like 1,000 milligrams total. So if we do Venifer, you do like 200 milligram infusion once a week for 5 weeks, or you stretch it out more. But my favorite lately are the Infed, the iron dextran, which is 1,000 milligrams. So you get it all at once. And they used to be really scared of those. Historically, they had a lot more chance of anaphylaxis, but the formulation has really changed and it's really safe. Very few people have allergic reaction to it. And it's one infusion, which is so great for a pregnant or postpartum person. And so they can get like that big amount all at once. And it's going to be like, look normal that they're going to have a ferritin of like 300. And to not be freaked out about that, because, baby's going to take it, pregnancy's going to take it, menses is going to take it. They just stop their iron for a little while. So maybe they just do a multi instead of a prenatal.
I know there's some prenatals that don't actually have iron in them because of the calcium,
that it'll affect
iron.
Yeah.
Does calcium keep iron from getting?
Yeah, in general, yeah. So I wouldn't want you to take your iron cap with a glass of milk, for example. That's not going to be the best way to absorb it. You're not going to get as much of it. But I don't like my patients to get too in the weeds with worrying about what's going to, like, that they have to take it with orange juice or vitamin C, and they have to do it away from their milk. And that's ideal. But most of the time when my patients get too many things in their head about like what helps and what hinders, then they just stop taking it, or they stop taking it regularly enough. And so I just have them find a time of day that they tend to have less dairy in their meal and just take it with that meal. There's also some research on that sometimes if you do a double dose every other day or every 2 to 3 days, you're going to absorb it better. But again, if I have my pregnant or postpartum mamas try and keep track of that, it ends up that overall they get fewer doses because they just are like, am I on it every other day? And then they just don't take it. And I'm just like, just take it. Even if you're getting 75% of it each day versus 90% of it every other day, sweet, just take it every day. So whatever's easiest. But yeah, calcium can affect the absorption of it, but I don't know. I'd rather there be some there than none. So I like the prenatals with iron.
What about like Floridix and liquid iron supplements?
I just don't find that to be a heavy enough hitter. It can be nice for those who really have digestive compromise, and that can help. But usually they have to take so much that it kind of gets nauseating. And so I like, companies like Thorne or things like that that choose types of iron that are a little bit more absorbable, like the bisglycinate or things like that. They tend to be less constipating and just more tolerated. But even if it slows things down a little bit, just take a little bit of magnesium with it, magnesium citrate, and that could balance it out. And again, like the benefits of having some iron in there. Some people are good absorbers and it's still going to take months to get their iron level up, but that it can go up. But if anybody has known digestive compromise, like irritable bowel or Crohn's or celiac, then I don't really usually even try through the gut because it's just gonna be such a slow process, and an infusion is really nice. Or if like they're in the middle of pregnancy or they're just about to give birth and they're gonna like be dropping on their iron anyway, so it's like, how do I get it faster to begin with? I like think a lot about where am I in this process and how much time do I have to raise it before it falls.
I love the idea too of like, it's just so much more efficient to have an infusion.
Well, a lot of time, it's just a big molecule to absorb for anybody. And it's a slower process when we're going through the gut. And so we put it right in the blood. So nice for those who their belly gets upset with it or they just can't absorb it. And it's so fast. I'm like, it's been a game changer for me, like how high I needed to dose oral iron in order to get ahead of the periods and the nursing and all that was hard before being able to do IVs. And for a while, we had to have iron deficiency anemia and not just iron deficiency in order to order an IV. And now that we can order it with iron deficiency without anemia is another game changer that's just so wonderful. I'm just so grateful.
Me too. Thank you so much, Stephanie.
Pleasure. Have a good afternoon, Emily.
You too. Bye.
Bye.
I hope that conversation gave you some clarity and maybe some validation if you've been feeling dismissed. Now, I promised you a story. So I was having a conversation with a client recently who had been dealing with nerve pain postpartum, and not just a little tingling, full-blown carpal tunnel in her wrists. And I had been telling her time and time again that she needed to go get assessed. And she did. And sure enough, they diagnosed her with carpal tunnel. They did a nerve conduction test and they said, congratulations, you have carpal tunnel. And that's it. Which is a whole nother story about my frustration with how that was treated. But she was also having tingling in her ankles and feet whenever she moved her ankles in a certain direction. She had been having nerve pain down the back of her leg from a previous injury that had worsened. And she'd been struggling, and no one had connected the dots, including me. So when she mentioned that she had started taking iron because she got tested for iron and had low ferritin, I asked what her ferritin level was. And she said, 18. 18! Here's the thing. Iron is not just going to help with making red blood cells. It's essential for producing myelin, which is the protective coating around your nerves. It's also needed for proper nerve signal transmission. So when your iron stores are depleted, your nerves can literally stop conducting signals the way they should. That's how you get numbness, tingling, and pain in your hands and feet. So it's likely that this patient had been struggling with this throughout her entire pregnancy, and it was just missed over and over and over again. And I want you to remember what Dr. Stefani Hayes said. The ideal ferritin level is around 100. And most people become symptomatic when they drop below 30 to 50. Right? My client was at 18 and her body was letting her know loud and clear. And her medical providers just said, take some iron supplements. When really what she absolutely needs is an iron infusion. So if there's one thing that you take away from this episode, it's this. Ask for your ferritin level, not just a CBC, not just checking for anemia, your actual ferritin level. And if it's below 50 and you're pregnant, postpartum, or nursing, or even not, have a conversation with your provider about how to actually get it up. Whether that's a more absorbable form of an oral supplement or an iron infusion, which should be accessible to you, especially if your iron levels are 18. You deserve to feel good. Not just getting by good, but actually good, completely good. Thank you for listening. I'll see you next time. New episodes drop every Wednesday. and you can find us wherever you get your podcasts. Follow me on Instagram at BeWellBabyPDX or just visit BeWellBaby.org. Send an episode to someone who's pregnant, postpartum, or just needs guidance. No one should have to do this alone. Welcome to the Be Well Baby podcast. You're in the right place.